And very good morning to you.
Yeah, good
Yeah.
evening, you guys. I think it's kind of late for you, right? Little bit?
Yeah,
It's
it is now going to be 7 here.
Yeah. It's
And,
nice to see you face to face. Yeah. We
yes.
emailed each other.
Yes, yes.
And Dr. Patra, would you mind opening
Hello,
your?
Hello, Dr. Dipti. I'm
Hello,
cannot
Dr.
see-
Patra. How are
We cannot
you?
see you.
Oh, you are not seeing me. Yeah. Are you able to? Is it?
Yeah, we
I
can
Not
think
see.
able to- Are you able to see me? It's not screen.
Your screen is, I mean,
There is some
there's a
problem.
lot of, there is some problem on the back.
Okay, I'll
of-
just take the help of this
IT person.
IT. Preeti, can you help me? This is no. So this is not coming. Please check it.
somehow I was taking a picture and adding it to my PowerPoint. And then somehow the picture I pasted into my screen. So I was trying to have it. So if you can see my screen, it's all like a dot, all immunostain. I don't know
Oh
how
my
to
God.
remove it. I'll take some help later on.
Right.
So the timing is not good for you guys, right? I mean, we should have it more in the India morning time. But then evening is better for you?
I mean, evening is better for a lot of people because they are, I
Okay,
mean, done with their
good.
work and.
All right. So
But-
everybody works late over there.
Can organize this in a Saturday or so in the evening. I think more residents can join because they are all
Yes.
in our department. It goes until 12 or so.
Yeah. Okay.
So I think, Anita, you can start talking about IO and then Dr. Patra will take over.
I didn't say hi to Anita, right?
Yes, sir. I'm starting it right away. So thank
Madam,
you.
ma'am is saying hello to you.
Oh, very good evening, ma'am. Here it is evening. So happy to connect
Hello.
with you.
Hello.
Yeah, thank you. Thank you so much for your time, ma'am. We're glad to meet you today. Yeah.
So why don't you start introducing the company, then gradually people will join in.
Yeah, sure, sir. I'm starting it, sir. Just give me a moment, sir.
Sure, sure. Anuradha, we are waiting. Yeah, are you logging in? Okay. Okay, sure. Thanks. Bye-bye.
Very good evening, one and all. So, I'm glad to welcome all the panelists and the moderators who has joined for today's meeting. Dr. Sambit K. Mahante, Head of Oncopathology and Translational Research, Co-Diagnostics, Haryana, India. Dr. Susama Patra, Head of Department, Pathology and Laboratory Medicine, AIMS, Bhubaneswar, India. Dr. Prasenjit Das, Professor of Pathology, AIMS, New Delhi, India. Dr. Neeraj Kumari, Professor and Head, Department of Pathology and Lab Medicine, Dean Academic, AIMS, Ravelli, India. Dr. Anuradha Shekaran, Director and Chief of Pathology, AIG Hospitals and Asian Institute of Gastroenterology, Hyderabad, Telangana, India. So thank you all for joining today's meeting. So we really appreciate your time. So I'd like to take 2 minutes to say a few things about International Association of Oncology. So International Association of Oncology, profitable association meant for research and development in the field of medical oncology, pathology, and other life sciences. So IAO is National Forum for the Researchers, academicians, doctors, practitioners for sharing their research and innovation in this field. We aim to bring together and provide a platform, encourage intellectual development, and providing opportunities for several networking and collaboration. So we organize several international events, meetings, conferences, research publications, academic awards, fellowships and grants, and so other services as well. So we bring together and we provide them a platform where they can present their research and share the knowledge and gain the networking opportunities as well. So with this note, I'm glad to have this particular webinar today with the speaker. So we kindly request Dr. Susama ma'am to take over the session. Please, ma'am.
Am I audible?
Yes, you are.
Yes, ma'am, you are audible.
Good evening, everyone. I would take the opportunity to introduce Dr. Dipti Dhol. She is a tenured professor of pathology, associate director of anatomic pathology, director of surgical pathology fellowship program, and director of GI pathology at the University of Birmingham in Alabama, USA. She is also a senior scientist at O'Neill Comprehensive Cancer Center, UAB. Her diagnostic expertise is in gastrointestinal, liver, pancreatobiliary, and gynecologic pathology. Her major area of research interest are neuroendocrine, pancreatic, hepatobiliary, and gastrointestinal tumors. She has been honored with multiple awards for outstanding contribution to residents' education, mentorship, and her excellence in teaching and medical education. She has been multiple presentations at various national and international pathology, including the US CAP, International United States and Canadian Academy of Pathology. She is a member of the Modern Pathology Editorial Board and a reviewer of many journals. She is also a member of the Executive Committee of Gastrointestinal Pathology Society and is currently serving as committee member of Pancreatobiliary Society and Hans Popper Liver Society. She has more than 150 publications to her credit. Now over to you, Dr. Dipti.
Hi, good evening, everybody. And I really like to thank Dr. Mohanty and all the moderators, Dr. Das, Dr. Patra, and Dr. Kumari and Dr. Sekaran for inviting me to speak today. And I want to thank all the participants for joining me today for this session. And I hope you find it educational and informative. So should I start now?
I think yes, you can start now. It is already
Okay.
time.
So I will share my screen. Give me a second. Okay, looks good. And you can hear me well, right?
Yes, yes.
Okay, so for today's session, I would like to give you an overview of the neuroendocrine neoplasms in general, which involves the gastroenteropancreatic system. These days we call it JEPNETs. And the whole focus is going to be how to make up the accurate diagnosis and what are the issues with this whole entity, which is a very broad category. So I'll try to touch upon the main part of my talk would be to make a diagnosis of these neoplasms in a metastatic setting. Not when we are doing the biopsies endoscopically, but when these tumors present as metastatic disease. And at that time, it's very important to differentiate the two spectrums of these neoplasms. One is the neuroendocrine tumor, which is well differentiated, and the other spectrum is a neuroendocrine carcinoma. And we'll talk about the morphological aspects, how to make the diagnosis morphologically, what immunohistochemical stains we will need to make that diagnosis. And if we make a diagnosis of neuroendocrine tumor, how do we grade these tumors? If I have time, and I don't know how much it's a 1 hour session, I will briefly go over the mixed neuroendocrine, non-neuroendocrine neoplasms. And I still have time, I'll touch upon mimics of neuroendocrine neoplasms. It's a really big topic, so depending on the time, we'll see what we can cover today. So neuroendocrine neoplasms are relatively rare neoplasms, but they are not actually that rare now, especially the two institutions I have worked, and we have neuroendocrine tumor excellence over here. But overall, the incidence has also increased worldwide, and partly because of the increased diagnostics and increased awareness of these tumors. And as I said, the neoplasm word is a very generic term which includes both neuroendocrine tumor as well as neuroendocrine carcinoma. And the point to remember is neuroendocrine carcinomas, most neuroendocrine carcinomas present with metastatic disease, but a subset of neuroendocrine tumors also present with metastatic disease, and out of which the liver metastasis is most common. And if we diagnose something as a neuroendocrine tumor, the most common primary site would be small bowel, pancreas, and lung. So for example, rectal neuroendocrine tumor or appendix neuroendocrine tumor almost never present as metastatic disease. So that we should always keep in mind. And how do we differentiate between the two? It's based on morphologic features. And that's the best part of it, because we all are histomorphologists. We all have access to good H&E. So if we can identify a tumor as having a neuroendocrine tumor, like a carcinoid-like features, which I'm going to show you in a moment, it's a neuroendocrine tumor. And when it's any poorly differentiated carcinoma, it looks very bad, then we think of neuroendocrine carcinoma. This is in the very simplistic term. If it has a resemblance to a neuroendocrine cell population, it's neuroendocrine tumor. If it looks like more like carcinoma, it's a neuroendocrine carcinoma. But obviously, it's not that easy, especially when the tumor becomes a high grade. And high grade term for neuroendocrine neoplasm is used based on the proliferative activity. So, olden times we used to say, oh, Ki-67 can help in differentiating carcinoid tumor from neuroendocrine carcinoma. Yes, it can help when it is very low. And yes, it can help when it is extremely high, almost approaching 100%. But when the high-grade neuroendocrine neoplasms, the Ki-67 is approaching 50%, then it is usually not helpful in differentiating neuroendocrine tumor from neuroendocrine carcinoma. So these neuroendocrine tumors, when they are well differentiated, we can diagnose them by functional imaging, which is commonly known as daughter-Tate PET scan. I think that, India, everything is available right now. So there must be daughter-Tate PET scan, which actually detects somatostatin receptors. So this imaging technique is actually very good in diagnosing neuroendocrine tumors. And obviously, to understand these neoplasms in general, it's very important to understand the genetics, the molecular biology of these tumors, which we are going to discuss a little bit here. Now, obviously, we don't have access to some of this information when we are dealing with the case. Clinical behavior absolutely gives you a final answer, how rapidly the tumor is progressing. And that basically decides the management of the patient. So here are the key features of neuroendocrine tumor. I know there are a lot of, I think there must be junior residents over here. So we should go to the absolute basic. Whenever we see organoid architecture, that means tumor cells are present in nest or they're present in trabeculae, and rarely they can be in sheets, and that can be a problem. Here you can see the nested appearance. Sometimes they can form glands right over here. And typically, they're very vascular tumors. So you will see rich vascular network over here. In this one, maybe not, you can't appreciate. So you can't appreciate all the features of these in every biopsy or specimen you have. But the stroma we see is hyalinized stroma. We don't see the typical desmoplastic stroma of carcinoma. And I think that can also be confusing in a biopsy. Again, the key is monotonous, the uniform population of tumor cells. Now we can get scattered, what we call as endocrine atypia. So there can be few large atypical cells. That does not make it anything carcinoma. And if we go high power, there's a salt and pepper like nuclei, like here, again, very monotonous population, very very granular, uniform chromatin pattern. And mitoses and necrosis are typically hard to find in these tumors. So that's a very characteristic neuroendocrine tumor histology. And there are two things which you keep in mind, that especially neuroendocrine tumors in duodenum and sometimes in rectum, you can see gland formation. So gland formation does not make you, you should not misdiagnose this as carcinoma, especially in a biopsy material. And the key is, again, if you ignore the gland formation for now and just look at the uniform population of tumor cells, you don't see that uniform population of tumor cells in a carcinoma. On the right-hand side, you can see a picture. This was another duodenal neuroendocrine tumor. Every cell has mucin in it. So even you can see mucin in a neuroendocrine tumor. This is something very rare. But again, the thing to appreciate is uniform population of tumor cells, which makes us think it's a neuroendocrine tumor. Anytime when we are making a diagnosis, we have to know what is the clinical correlate. These tumors, often patients present with non-specific symptoms. And it is said that, sometimes it takes years to make this diagnosis because patients present with very non-specific symptoms. They typically behave very indolently. And as I said, 1/5 of these neuroendocrine tumors can present as metastasis. So present as metastasis does not make it carcinoma. Before 2010, before 10 years, there was a very confusing terminology for these neoplasms. Every time patient presented with metastatic disease, they used to be called carcinoma, not anymore. So we should know neuroendocrine tumors. However low grade they look, they are actually malignant neoplasms and they may present as metastatic disease. Some of them may produce hormones, and we all are familiar. They produce the serotonin, and that can lead to carcinoid syndrome, which is flushing, and very characteristic syndrome, very characteristic symptoms we get. If we have serology, serum chromogranin is helpful in making the diagnosis of neuroendocrine tumor, especially in a metastatic setting. But remember, serum chromogranin can be elevated in a lot of different conditions, lot of chronic conditions. So that's also not specific. Daughter-Tate PET scan is very sensitive and very specific for the diagnosis of neuroendocrine tumor. And I will not go to site-specific nature of this because every site has a different biology, have a different pathologic features. So, for example, appendix neuroendocrine tumors are different. The rectal neuroendocrine tumors are unique. The gastric neuroendocrine tumors are unique. They're classified separately. That's a completely different lecture. So I'm not going to go there, but their behavior is very site-specific. And obviously, grade is very important, which is dependent on Ki-67 proliferative index. And opposed to neuroendocrine tumor, a different spectrum, the very end, here is carcinoma. Actually, in carcinoma, it looks very malignant. You will not think of neuroendocrine tumor most of the times. There are sheets of cells, and both these pictures you can see on the right-hand side, you can see necrosis, like sheets of necrosis. But key again for neuroendocrine carcinoma, as opposed to other carcinoma, is the monotony of cells. Even though they're highly atypical, there's a uniform population of tumor cells. They can be small cells, they can be large cells, but the key is very atypical, lots of necrosis, lots of mitoses. Now, if we do Ki-67 in this, it's typically very high, but a large cell neuroendocrine carcinoma can have actually around 20 to 30% Ki-67. So the range of neuroendocrine carcinomas is huge, especially in a setting of large cell neuroendocrine carcinoma. To know about clinical characteristics, obviously, they are very aggressive tumors. The median survival is 7.7 months. And it's interesting because once in a metastatic setting, is the primary site important? I used to think they're not important, but recently there was a SEER database and they reported primary site actually has some importance prognostically. And regarding the histologic type, small cell carcinoma versus large cell carcinoma, not clear, some papers say large cell do better, but actually So far, it is not clear whether any histologic subtyping of neuroendocrine carcinomas is indeed clinically relevant. They do look different though. And within this category of carcinoma, it seems Ki67 have some prognostic value. For neuroendocrine carcinomas, less than 55% may do better than Ki67 of 100%. And we all treat these neuroendocrine carcinomas with platinum-based chemotherapy, and that's why the diagnosis of neuroendocrine carcinoma is important. And even Ki67, besides prognostic, it has predictive value. There's a very famous paper, Nordic study, which is from the Nordic countries in 2013, and they showed that tumors having greater than 55% Ki67 responds better to chemotherapy than having less than 55% Ki67. So the problem is when you get these biopsies, small biopsies, and when the tumor cells are not being organoid fashion, because tumor cells are present in sheets, it's a small material. It is hard to make a diagnosis. Is it a neuroendocrine tumor or a neuroendocrine carcinoma? The tumor is present in sheets. I think we will think of neuroendocrine differentiation because of the uniform population of tumor cells. How atypical are they? It's in our eyes. Some people may think it's very atypical. And, I am not sure about it. There's not much necrosis over here. I don't see obvious mitotic activity. So I think in a case like that, especially in a small biopsy, one thing that can be very helpful is the Ki67. So in this case, actually, there was a lot of crush artifact. In fact, it was diagnosed as neuroendocrine carcinoma, believe me. But if you do Ki67, such few proliferative cells. So this was actually a low-grade neuroendocrine tumor, not neuroendocrine carcinoma. So Ki67 in very opposite ranges can actually help you with the diagnosis of neuroendocrine tumor versus carcinoma. So this patient actually, metastatic neuroendocrine tumors are typically treated with lanreotide, especially the low-grade ones, or everolimus if it's a pancreatic primary. And sometimes they're treated with this peptide radionuclide therapy. So typically we start with this and not with the platinum-based chemotherapy. So the huge difference in making this diagnosis. And this was the Ki of 4%. Now going over the features of small cell versus large cell, we all know small cell is very diagnostic, small nuclei, cytoplasm is scanned. We don't see nucleoli in small cell, and they're typically present in sheets. For large cell, there are larger nuclei, cytoplasm is moderate, and we typically talk about prominent nucleoli in large cell. And in large cell, we can have some kind of a organoid pattern. So I think large cell neuroendocrine carcinomas can be confused as high-grade neuroendocrine tumors, and I'm going to show you several examples. In JEPNET's world, gastroenteropancreatic neuroendocrine neoplasms world, we know there are some neuroendocrine carcinomas which we cannot categorize as small cell and large cell. And as I said, they may not be clinically relevant so far, at least in JEPNETs, in gastroenteropancreatic neuroendocrine neoplasms world. So here is the polypectomy specimen in a transanal excision. And we can see a little bit of an adenoma here, but then there are solid sheets of cells. Now, when we see an adenoma over here, we see solid sheets of cells. Maybe that idea doesn't come. We'll say, oh, polydifferentiate carcinoma. But I think what is striking over here is monotonous population of tumor cells, prominent nucleoli. So I was thinking of large cell neuroendocrine carcinoma. And obviously, to make a diagnosis of large cell neuroendocrine carcinoma, we need synaptophysin and chromogranin staining here, which is pretty positive over here. So this was called large cell neuroendocrine carcinoma, and the Ki67 was very high. And obviously, the tumor is very aggressive, lymphovascular invasion was present. I'm going to, just to show you that small cell versus large cell, there's a lot of literature as I've listed on the right. Not sure about survival difference between these two subtypes, not sure any treatment difference between two subtypes. In some literature, it says large cell neuroendocrine carcinomas, there's some molecular evidence that they have more molecular evidence of an adenocarcinoma, so they may be given an adenocarcinoma chemotherapy. But right now, I mean, there are not much differences. Now, in large cell neuroendocrine carcinoma is a distinct entity in lung. So far, not in GI, not in gastroenteropancreatic system. And the most recent study in 2022, they also did not see any clinical or pathological or molecular difference between these two subtypes. It's just different histologically, but so far, no clear proof that they are indeed different. Now, this is perhaps the most important slide. The immunohistochemistry is very important to make a diagnosis of neuroendocrine neoplasms, even though the morphologic features are key, the monotonous population, but there are so many mimics, and we can really go down the tubes if we don't think about other differential diagnoses. I want to talk about a little bit INSM1, which is a newer marker, and we have it here, is considered more sensitive and specific. One thing is said about INSM1, it picks up most neuroendocrine neoplasms. We all know synaptophysin is sensitive, not specific. Chromogranin is more specific, not sensitive. INSM1 captures more sensitivity and specificity. I have to say, when doing this now, I do see a lot of positive, weak, patchy positivity in tumors, which I don't believe are neuroendocrine neoplasms. So to me, it's not that specific. So it has to be used in a right morphological setting. These are the stains, keratins. You know, at some point I didn't do keratins for neuroendocrine neoplasms, but I got burned once or twice. So keratins are absolutely must, because there are mimics such as paraganglioma, which can really look like neuroendocrine tumors. So keratins, because GI, I'm going to say JEPNETs for gastroenteropancreatic. JEPNETs they are epithelial neoplasms, so they should stain with keratins. Having said that, there are rare neuroendocrine neoplasms which are negative for keratins, so you have to try multiple keratins. S100 SOCs tend to rule out melanoma, which can express neuroendocrine markers. Squamous cell carcinoma can sometimes look like small cells, so squamoid markers are important. We'll talk about site-specific tumors, breast carcinomas, prostate carcinomas, adrenal cortical carcinomas. They can have neuroendocrine differentiation. They can look like neuroendocrine carcinomas, and so the site-specific markers are very helpful. And others, Ewing sarcomas, also recently described, they can occur in the gastroenteropancreatic organs, and they can express neuroendocrine markers. And Merkel cell, we're going to talk about if we have some time. So here I talked about the morphologic features of NET versus NEC. I wish we could make it a little bit more interactive, but maybe next session was a lot to talk about. Here is the tumor, and there's lots of necrosis. And I said in neuroendocrine tumor, you usually don't get necrosis, right? So I'm getting confused over here. Is this like a, and you can start seeing large atypical cells too. Is it atypical enough to call it carcinoma? Or we have some uniform population of neuroendocrine cells? What is it? Is it a grade 3 neuroendocrine tumor, or is it a grade 3 neuroendocrine carcinoma? And Ki-67 is 20 to 30%. I think these cases are really, really hard, and we really need to do a lot of clinical workup, look at imaging, do immunostains, and here we talk about how to differentiate between them. I've already discussed the histologic features differentiating between the two. Now, the immunohistochemistry, P53 and RB, there's a lot we talk about. Okay, neuroendocrine carcinomas can show P53 mutant pattern, but not all, 80 to 90%, I guess. And RB, maybe 60% tumors, neuroendocrine carcinomas would show loss of RB. But not all neuroendocrine carcinomas can have P53 mutant pattern or RB loss. So again, it is a problem. And recently, there are some literature, and I have quoted here in my presentation, a subset of grade 3 neuroendocrine tumors will show P53 mutant pattern staining. So it makes it really confusing. So these stains will not give you an answer just by doing these immunostains. Yeah, for pancreatic primaries, if you have ATRX, you can do that stain, and only a subset of pancreatic neuroendocrine tumors will show loss of ATRX. And I am pretty sure DAX and menin are not available in most labs. To me, clinical history is absolutely useful. The previous case I showed you, patient had a known history of pancreatic neuroendocrine tumor 3 years before, and now was presenting with pancreatic with liver metastasis. So because of the history of pancreatic neuroendocrine tumor, it was called grade 3 neuroendocrine tumor. And, and imaging can also help. Typically for grade 3 neuroendocrine tumors, PET dotatate is positive. And as the tumor gets more higher grade, FDG PET would be positive. So FDG PET is positive in neuroendocrine carcinomas. But all of these things, there still can be a problem differentiating between the two. And the best you can do is just call it high-grade neuroendocrine neoplasm and discuss it in the comment. And in a setting like this, when it is difficult, they make a clinical decision based on how the patient is doing clinically. This paper from Laura Tang, she was my mentor when I was a fellow at Memorial Sloan Kettering, published in 2016, very nicely described how can we take help of all these features, clinical features, imaging features, clinical history to differentiate between the two. This is what I just talked about. Remember, neuroendocrine carcinomas can show associate component of adenocarcinomas. In all JEPNETs, we talked about RB and P53. Loss of SMAD4 is seen in 50% of pancreatic malignancies. So if we see loss of SMAD4, also helps in neuroendocrine carcinoma. So very nicely mentioned over how we can differentiate this feature. I do want to acknowledge this paper, which was recently published in 2021. All these big neuroendocrine giants here, they just, including my mentor, Laura Tang, Dr. Klimstra, also my mentor. He taught me on neuroendocrine tumors. They all looked at these high-grade neuroendocrine neoplasms. These were the tumors which was a part of the Nordic study, the big Nordic study. We talk about that chemotherapy is useful for tumors with Ki-67 greater than, not useful, they're more effective for tumors greater than 55%. So these authors, they came together, they looked at all tumors, and they came up with these morphologic features. Which morphologic features are best to differentiate G3 tumors from neuroendocrine carcinoma? And we discussed that organoid growth pattern, more typical of neuroendocrine tumor. And as I said, neuroendocrine tumors are very vascular. So if you see capillary network in direct contact to tumor cells, and absence of desmoplastic stroma is likely a neuroendocrine tumor. So yeah, if you are a morphologist, this is a good paper to read as well. I recently went to a European Congress of Pathology meeting, and they talked about P16 immunohistochemistry, and I got really excited about it. Here is Dr. Yumitsu from UCSF. This is also a multi-institutional study. Sorry, this is not 2013, it's 2023, just published this year. They actually did a molecular study on all high-grade pancreatic neuroendocrine neoplasms. And in that study, they also applied P16 immunohistochemistry, and it seemed to be like a very good marker. And we all have P16. So if you can see, 69% of neuroendocrine carcinomas, and in our study, when we quickly did this, 80% of neuroendocrine carcinomas were P16 positive. Remember, P16 positivity, we need to see diffuse and strong, not patchy positivity. Patchy positivity, I do GYN pathology too. Patchy positivity is considered negative, in my opinion. So, and all of the G3 NETs they studied and we studied, none of them were P16 positive. So again, this seems to be a newer stain, promising stain, but anytime when the stain we talk about new, we obviously find some overlap. This is SSTR2-IHC, we have it. I think it is also helpful. This is the basis for the functional imaging I was talking about, dotatate scanning. Most neuroendocrine tumors will show diffuse strong staining. And I have to say though, when we deal with grade 3 neuroendocrine tumors, a subset of grade 3 neuroendocrine tumors, around 15 to 20%, will actually show negative to weak staining. So again, any stain by itself is not perfect. And I have seen SSTR2 staining in neuroendocrine carcinomas as well, but not that typically strong and diffuse. So these are two stains also that can help differentiating neuroendocrine tumor from neuroendocrine carcinoma. Here is the case. This is the strong staining, strong and diffuse staining I like for SSTR2 for neuroendocrine tumors. And this is one example of neuroendocrine carcinoma I'm going to show you. It is staining with SSTR2, but see, not that strong and diffuse. So the pattern of staining is very important. And this is the courtesy of my postdoc research fellow. She did this, Dr. Fatma Gandor. She did this study. This is a neuroendocrine carcinoma, and here's a strong and diffuse block-like positivity for P16. And this is a grade 3 neuroendocrine tumor, which is, you see P16 in the high power. If you go, it will look positive, but I think most were negative. This is the only positive case which one person thought was positive, but if you look in low power, not as strong and diffuse. So I would consider this as patchy staining. So this is grade 3 neuroendocrine tumor. This is an example of an ileal tumor. This is a resection case. Most of the ileal tumors, when I say tumors in general, I meant a neoplasm. When you deal with an ileal neuroendocrine neoplasm, you always think of neuroendocrine tumor. They are solid sheets. I don't see outright atypia in this. So I was a little confused. Is this neuroendocrine tumor? Is it a grade 3 neuroendocrine tumor? Or it's a neuroendocrine carcinoma? But then we start seeing these large areas of necrosis. So, high suspicion for neuroendocrine carcinoma. Obviously, it's stained with synaptophysin. But look on the right. We also did RB stain, and beautifully it showed loss of RB. So this was very helpful. This also showed P53 mutant pattern of staining. And this is the same case which also had SSTR2 staining, but patchy, not strong and diffuse. So we called it neuroendocrine carcinoma, and the Ki was very high in this case. Patient was treated with chemotherapy here, platinum-based chemotherapy, unfortunately died in 2 years. This is another very challenging case. High power view, solid sheets. Obviously, if it was organoid, if I could appreciate the vascular pattern, if I could appreciate the stroma, not much, solid sheets of cells in a small biopsy. And you see prominent nucleoli over here. So is this a large cell neuroendocrine carcinoma, or it's a grade 3 neuroendocrine tumor? Very monotonous, but prominent nucleoli. And Ki67 on the right is actually very high. We even though we didn't see a lot of necrosis, but very high Ki67, almost 100%. And this patient underwent actually molecular testing. And this patient also showed P53 mutation. But look, also mutation in DAX, NF1, and menin. So there was mutation in there was DAX and NF is seen in neuroendocrine tumors. Menin is seen in neuroendocrine tumors. P53 mutation is seen in neuroendocrine carcinoma. But this tumor on imaging was DOTA-TATE negative. So much of an overlap we can see between a grade 3 neuroendocrine tumor or neuroendocrine carcinoma. So these cases are very tough. Usually in a case like that, say high-grade neuroendocrine neoplasm, they can look at clinical, they can look at imaging. Obviously, DOTA-TATE was negative, tumor was rapidly progressing, patient was started on chemo on this tumor. And on Yumitsu's paper I was discussing, which was published this year in Modern Pathology, they did discuss that P53 can be expressed in grade 3 neuroendocrine tumors, so P53 is not the answer. And they did discuss some tumors actually do have molecular overlap between grade 3 neuroendocrine tumors versus neuroendocrine carcinomas. So it's not easy in some cases. Let's see how much time I have here sometime. Yeah. So for a metastatic, if the tumor presents, if a neoplasm presents at metastatic setting, obviously most of my talk, I discussed how to make a diagnosis of neuroendocrine tumor versus neuroendocrine carcinoma. It's important. I think we can do it in most of the cases, most cases. The few cases I'm showing, they were rare cases. I struggled with them and they're there. So most of the times you will be able to make a diagnosis of metastatic neuroendocrine tumor versus metastatic neuroendocrine carcinoma based on all the features we just discussed. So what should we do if we diagnose a neuroendocrine tumor? Obviously, we need to grade the metastatic tumor. Grading is still important prognostically and for management. And for neuroendocrine carcinomas, there's a whole big story, and let's see if we can cover that or not. Otherwise, we'll do it in the next session. So if we diagnose a neuroendocrine tumor in a metastatic setting, and we don't know of the primary site, most of the times clinically, they know it sometimes. Sometimes they don't know. And we do have stains to help us out. Remember, for a neuroendocrine tumor, which is well differentiated, to figure out where the tumor is coming from. And sometimes it's very satisfying if the tumor is strongly. So these are the stains, and I'm going to talk about these stains. Now, because of the time, we'll not go to each and every stain over here, but I would recommend this paper from Dr. Bellisi. He published in Human Pathology. A very good friend of mine. He has written a lot about neuroendocrine neoplasms. Sorry, the PMID is in blue. Didn't mean to do that. If you read his papers, his very comprehensive and very detailed papers. His papers are really very nice, very educational. So, and part of this work, actually, I did with Dr. Mohanty. He was my fellow, and we did this work together. So I really want to acknowledge him. This is the metastatic tumor in a liver. Morphologically, you can say neuroendocrine tumor, and morphologically neuroendocrine tumor from small bowel. They typically have that very nested look, which is also called type A. Cytoplasm is very granular, and this is strong in diffuse positivity for CDX2. So we can say likely small bowel primary site. But it's not specific because a subset of pancreatic neuroendocrine neoplasms can stain with CDX2. But if we do a panel of stains, for example, this is a neuroendocrine tumor in liver. And it's a pancreatic, this is staining with islet-1. And islet-1 is a sensitive marker for pancreatic neuroendocrine tumor. And actually, it's not seen in small bowel tumors at all. So, this can help in a panel if we have islet. We don't have islet-1, sadly. And I think islet-1 is not available in most laboratories. So that's a problem. And Paxil, initially, we used to have polyclonal antibody. Now we have a monoclonal antibody. So monoclonal Paxil does not work. It's a PAX6 antibody, and PAX6 antibody, I think it's not available in most laboratories. This is rectal NET. This is just for interest. As I said, most of them do not present as metastatic disease. The only reason I'm showing is islet-1, which is a pancreatic marker, is also very nicely expressed in rectal neuroendocrine tumors. But SAD-B2 also is positive in rectal neuroendocrine tumors, and that strong diffuse positivity for rectal neuroendocrine tumors is not typically seen in pancreatic tumors. So this was a review paper we did long time back, and we just summarized the stains, how it can be helpful. TTF1 in a metastatic setting for neuroendocrine tumors, again, well-defined neuroendocrine tumors. If you find positive, it is helpful. It is kind of it's kind of specific, but not sensitive. We talked about CDX2, you can read this. I would suggest reading Bellisi's paper. It's more recent. Again, in a metastatic setting, grading is very important, and we grade it based on Ki-67 index. Why grading is important? Prognostically and for therapeutic. For some low-grade tumors, even in metastatic setting, they will just watch. They may not treat it. For grade 2 tumors, for higher KIs, they may resect it, they may give lanreotide. And for G3 tumors, even if it's a G3 tumor, if Ki is very high, they may think of some chemotherapy, not platinum-based, alkylating agent, or the other therapies as well. And if we figure out it's lung neuroendocrine tumor, sometimes lung presents as liver metastasis. If TTF1 is positive, we can actually call it typical versus atypical carcinoid because they use that terminology. So we can use the proper terminology if we know where the tumor is coming from. We all are aware of this grading. And just to let you know, the recent grading in 2022, which is not published, WHO grading, Not much has changed with the grading. So the grading stays the same. And this is just that one paper I will share we did here in the metastatic setting. And Dr. Strasberg, he's an oncologist. This is also a very well-known paper. He clearly showed even in the metastatic setting how important it is to grade. High-grade tumors do badly and low-grade tumors do fairly well. This is typical grade 1 neuroendocrine tumor on the left side, grade 2 neuroendocrine tumor on the right side. We all know Ki67, we need to count if it's a borderline areas. In this, the left one, I will not count, too low. I would just say less than 3%. And in the grade 2, if it is falling, but I think it is 10%, but if it's not sure, just take a picture on 20x and just count these tumor positive cells. This is a grade 3 neuroendocrine tumor. One would not assume it's grade 3 neuroendocrine tumor, looks like a low grade. Didn't see many mitoses, but Ki67 shows fairly positive cells. So good, it is first counted as 22%, so grade 3 neuroendocrine tumor. And here, some grade 3 neuroendocrine tumors I told you can make it very confusing. These are the ones where you need to do all the clinical and immuno workup to make sure this is grade 3 NET. There's another case, imagine this is 60% Ki67. Can I call it neuroendocrine carcinoma? I'm a little bit hesitant. I would do all the workup which we just discussed. And sometimes, when we look at neuroendocrine tumors, this is actually pretty rare. I do look at a lot of sections of neuroendocrine tumors of primary site, metastatic site, because sometimes if we see little morphology change, high NC ratio, little bit more crowding of cells, actually, they may show high-grade transformation. And Dr. Tang has written about this in beautifully that you can get sometimes high-grade transformation from a low-grade neuroendocrine tumor. About grading issues, typically take one block of primary metastatic, regional metastasis or distant metastasis. I try to look for morphology. If there's more mitoses or more atypia, I try to pick that block. If I don't have any, if everything looks the same, I just pick one block of the largest tumor. You need to pick hot spots and you need to really count when at the borderline areas, as I said. Now, what should be counted? Ideally, every cell should be counted, even with this light staining tumor cells. Sometimes if it's very light, I might ignore it, but there are some darker staining cells, there are some lighter staining cells. So traditionally, everything is being counted, but I came across this paper published last year. They actually counted only strong staining cells. And in their conclusion, they said the stronger staining cells correlated better with overall survival. They compared with traditional counting method with this. So maybe things will change in the future. I think I have 15 more minutes. Should I can go over some more, I think. If it's not, just let me know. This is a metastatic neuroendocrine carcinoma, high-grade cytology, very high Ki67. Do I stop for that? Maybe one thing we really need to do is exclude Merkel cell carcinoma. Sometimes Merkel cell carcinoma can present as metastasis, and these three stains are helpful. CK20, very characteristic staining we see. I'll show you a picture. Polyoma virus staining, we may not have it. It's pretty specific from Merkel cell carcinoma. This is the study, again, I did with Dr. Mohanty. We didn't find any staining in the other high-grade neuroendocrine carcinomas, just Merkel cell carcinomas. But not all Merkel cell carcinomas are positive for polyoma virus. And SADB2 is also a marker for Merkel cell carcinoma. So this is very characteristic powdery chromatin, very characteristic histology of Merkel cell carcinoma. On the right, you can see CK20 dot-like staining, and that is ISH testing for polyoma virus. This was a very nice case. We had a pancreatic biopsy. We could have called it neuroendocrine carcinoma, but it was CK20 dot-like positive, and we did RNA in situ hybridization for polyoma virus. So this was actually Merkel cell carcinoma, not the usual pancreatic neuroendocrine carcinoma. So even in a high-grade neuroendocrine carcinoma setting, we can do CK20 and to rule out Merkel cell. And otherwise, we should know in high-grade neuroendocrine carcinoma, site-specific markers usually do not help. Even though if we see strong diffuse positivity for TTF1, yes, statistically, the lung neuroendocrine carcinomas are most common, but around 30 to 50% of extrapulmonary neuroendocrine carcinomas can be positive for TTF1. The same thing, if you see diffuse strong positivity for CDX2, yes, we should think of a GI neuroendocrine carcinoma, but that can also be positive at other sites too. So this was a paper I just want to show. I like this one because we used to believe neuroendocrine carcinoma from all different sites. They're all same. They're all treated with platinum-based chemotherapy. But in this very nice paper, they actually showed there are site-specific changes. So for example, colorectal neuroendocrine carcinomas will show BRAF and KRAS. And, esophagus will show with more Notch 1, and the stomach ones, will show more beta-catenin. So they're showing, and more importantly, they were showing, they have particular inhibitors. So they personalized therapy can be given in these neuroendocrine carcinoma patients. For now, it's all platinum-based chemotherapy. Just to touch I said in a more that neuroendocrine carcinomas are associated with adenocarcinomas. And actually, if you really look at these cases, a lot of 40 to 60% of cases have actually adenocarcinoma component. And when these components are greater than 30%, we call them minins, which is mixed neuroendocrine, non-neuroendocrine neoplasms, which is a big which is basically a category of all kinds of tumors which can show neuroendocrine neoplasm and non-neuroendocrine. Of course, the most common subtype is manic, which is adenocarcinoma and neuroendocrine carcinoma. Here you can see adenocarcinoma on the top, neuroendocrine carcinoma on the bottom. The same thing, adenoma on the top, neuroendocrine carcinoma in the bottom. Same thing, GE junction case, adenocarcinoma on the surface, neuroendocrine carcinoma in the deeper layers. Another case, this is another GE junction. You can see this was actually a very nice case. Tumor cells present in nest, right? When we said nested architecture, monomorphic appearance, we should think of neuroendocrine carcinoma. Now, there were also these gland formation over here. So I think there were both components over here. Remember, neuroendocrine carcinoma can express intracytoplasmic mucin. It can have gland formation. So this is monomorphic population. I think that's a large cell neuroendocrine carcinoma. Everything was positive for synaptophysin chromogranin, but there was glandular component as well. So if this was greater than 30%, we will call it minin or manic, but there was mostly large cell neuroendocrine carcinoma here. I heard in ECP, European Congress of Pathology talk, they might remove that 30% criteria for minin tumors. Just to tell you that when we have adenocarcinoma and neuroendocrine carcinoma together, these tumors have shared mutations. So most likely it's arising from a single progenitor cell very early on, and then they divide. Some of them go to adenoma phenotype, the other goes to neuroendocrine carcinoma phenotype. So they do have differences. They have mutations exclusive, but they also have a number of shared mutations. And you can see here shared mutations in P53, KRAS, and APC. Mostly these are colorectal neuroendocrine carcinomas. I think I will stop here because there's a huge list of differential diagnoses, unless you want me to go quickly just to make sure we are comprehensive about this. But I will wait for the moderators to tell me.
Deepti, you can continue. Please continue.
So just to tell you that neuroendocrine tumor carcinomas, first, we make a distinction between tumor and carcinoma. This is monotonous population of cells, lots of mitoses, neuroendocrine carcinoma. If you're not sure it's grade 3 neuroendocrine tumor, do the stains. But it's not, the story does not end with neuroendocrine tumor versus neuroendocrine carcinoma. This was also a pancreatic biopsy. So this is all positive for neuroendocrine markers. We did P53, RB, we knew it's a neuroendocrine carcinoma, but this tumor was also expressing GATA3 and ER. So this was actually a metastatic breast carcinoma with neuroendocrine differentiation. This is again this paper I did with Dr. Mohanty. We published this in Modern Pathology, just showing you these two tumors morphologically. A metastatic neuroendocrine, GI neuroendocrine tumor in a breast versus primary breast, morphologically, they can look very similar. They can express both neuroendocrine markers. But in our study, we found GATA3 was positive in breast tumors, not in JEPNETs or JEPNET neuroendocrine carcinomas. And here is the table we had, low numbers, but this was a while ago. This is another neuroendocrine carcinoma in a liver biopsy, where, very monotonous population. We do see some gland formation. This one was a male patient, and this patient had a prostate carcinoma history, and it was positive for prostate marker. So this was a metastatic prostate carcinomas. So again, it's neuroendocrine carcinoma is not enough. Sometimes it's by site-specific diagnosis. This was a case, I got a text from my previous fellow, Dr. Dahl, my clinician is asking me to grade this neuroendocrine tumor. And I said, okay, did you do synaptophysin chromogram? She said, yeah, it's positive. But they did not do keratin in this. And actually, it was keratin negative. So this was a paraganglioma. And no needed to grade as grade 1, grade 2, grade 3. This is another case of paraganglioma. It expresses neuroendocrine markers, but keratin would be negative. I think I almost misdiagnosed this as neuroendocrine tumor. This was in the stomach wall, but this was not positive for keratin. And this is collagen 4 stain. So this was a glomus tumor. And this was also positive for smooth muscle actin. This was called as neuroendocrine carcinoma in a liver biopsy, but you can clearly see two population of cells. And if you look at, this is the two population of cells. One looks less cytoplasm, the other one looks more cytoplasm. This is the chromogranin stain. It's kind of patchy. The tumor cells with larger cells are showing less staining. And the Ki-67 is very high. So we should always think of mixed acinar endocrine carcinoma. So this is the trypsin stain. So trypsin positivity makes a mixed acinar endocrine. This is another tumor, monotonous population of tumor cells, looked high grade. Differential is neuroendocrine carcinoma. This is pancreatic biopsy from acinar cell carcinoma. This is the BCL10 stain, which is positive. So this is acinar cell carcinoma, not neuroendocrine carcinoma. Remember, acinar cell carcinoma can stain with synaptophysin. It's typically negative for chromogranin. One other case, small biopsies. It was positive for synaptophysin. It was focally positive for chromogranin. This is synaptophysin, that's chromogranin. I almost was not doing trypsin because it's a sent out test. And this is trypsin stain. So the diagnosis is acinar cell carcinoma. And remember, acinar cell carcinoma can express some neuroendocrine markers. Unless there's two different populations, we just call them acinar cell carcinoma. And solid pseudopapillary tumors, sometimes, especially in frozens, can look like neuroendocrine tumors, but they have this characteristic morphology. Tumor cells go away from the pseudopapillary cores. And there's perfect stain for this beta-catenin. These can also be positive for synaptophysin. And this is one case I remember. I was thinking of neuroendocrine tumor, pancreas resection, and it did stain a little bit with neuroendocrine markers, but there was some reason. I think keratin was dead negative. This one was positive for EWSR rearrangement. So this was Ewing sarcoma on pancreas. So lots of differential diagnosis for neuroendocrine carcinoma. So one lesson to learn is must rule out mimics. Please use proper nomenclature for neuroendocrine neoplasms. When you say neuroendocrine tumors, the management is different, prognosis is different. Try your level best, use the morphological clues we discussed, use the IHC workup we used. Once you make a diagnosis of neuroendocrine tumor from neuroendocrine carcinoma, if there's no known primary site, you can do those stains we discussed to differentiate the primary site. If needed, sometimes they know it clinically. For neuroendocrine carcinomas, rule out Merkel cell. It's rare, it's not that common. And in a difficult case, when you cannot tell, don't commit it. Just say high-grade neuroendocrine neoplasm. Let them do molecular. Let them look at clinical and imaging, and for the proper clinical diagnosis. And I think I will end right here. I'm open for questions. Thank you very much for listening. And that's it. Thank you. I will stop sharing. So.
Hi, Dr. Dipti. Very comprehensive and practically relevant presentation. I had a couple of questions, but for the sake of time, I will ask one or two. Importantly, you just talked today regarding the metastatic tumors, neuroendocrine tumors, and the importance of Ki-67 in both the sites. So, what about the practical utility of the NSI? Because it is thought to have a better prognosis if they are microsatellite unstable, or PDL1 stain or HDHB stain. What is your experience?
I'm sorry, the voice is a little bit not clear. I think you're talking about microsatellite instability, right?
Yeah,
It was
yeah. Yeah,
so.
he's
Sambit, what was the question again? Can you repeat it?
the question from Prasenjit is your take on MSI, SDH staining, and PDL1 in neuroendocrine neoplasms.
All right. So regarding microsatellite, MMR, immunohistochemistry, a subset, I would think 10 to 15% of neuroendocrine carcinomas will show loss of mismatch repair proteins or microsatellite instability. I have seen very few, so it's a low percentage. So I think and I know there's a talk about giving these immunotherapy for some of these patients. So I think it never hurts to do microsatellite instability testing by PCR or mismatch repair proteins if immunotherapy is being contemplated. I don't think it is a routine practice for people to do MMR IHC, but I have seen in my practice very few cases with loss of MMR staining. And I've read it that it's one kind of therapy patients can use. Currently, we are not doing PDL1 here for neuroendocrine carcinomas. So, and I think the first line of therapy is still platinum-based chemotherapies because tumors are very aggressive. But there's a talk about immunotherapy. So it doesn't hurt to do MMR staining. That's my take. But you all are very have experience. You can share your experience with me here. About STH staining, yes, for paraganglioma, we should do STH staining because, we can always, they are familiar tumors and we can show them the hereditary link for these tumors if these come across pheochromocytoma or paragangliomas.
Just to add to the point of MSI, I mean, we actually did a project on doing MSI in small cell carcinomas and also looking at the DNA mismatch repair genes. In both the pathways, they are kind of mutually exclusive. The percentage is very low, particularly in the NECs.
Yeah, I think roughly 10%. That was
it's pretty low.
Yeah. Anything else?
One of the moderator want to take the question answer session with Dr. Dol. Neeraj?
Yes. Hello. Good evening, everyone. Hello, can you hear me?
Yeah, we
Yes.
all hear you.
It was thank you, Dr. Deepti. It was a very nice, crisp talk, and you touched almost all the issues which are practically useful, like differentiating between NET and NEC, as well as the mixed neuroendocrine and adenocarcinoma thing, which we face almost every day in practical reporting. So
thank you very much.
Thank you because giving a very practical tips for the residents.
Yeah. And would you like to take the question answer with Dr. Dol, Neeraj?
Yeah. Okay. So there is one question which says, does the treatment differ in NET G3 versus neuroendocrine carcinoma?
Very interesting.
So this is a question.
Yeah. I think there's a lot of discussion. I think these cases are discussed at the tumor board. My impression is if a NET G3 has more than 55% Ki or more than 60% Ki-67, very high Ki-67, and the patient is rapidly progressive, they do give chemotherapy in some patients. It's just if NET G3 with 25% Ki, 30%, it's a continuum of Ki-67. I don't think they're giving as a first-line chemotherapy. They are giving biologic therapy, PPRT therapy. I've heard some pancreatic grade 3 NETs being treated with different chemotherapy, not platinum-based. So I think it's not standardized yet, but at least the Nordic study, and it says the chemotherapy, even if you give chemotherapy to patients of grade 3 NET with less Ki-67, like 30-40%, they do not respond as well. So to me, the first line is not chemotherapy for grade 3 NETs. That's why it's important to differentiate between the two. But if his Ki is high, if patient is rapidly progressing, DOTA-TATE scan is negative, they may go for chemotherapy.
Yeah, okay. So the next question is, I think you already covered it in your presentation. The question is, should we grade neuroendocrine tumors at metastatic sites if it is the
Absolutely.
only specimen? So I think you already discussed it and we should grade it. The other question is your experience with squamous cell carcinoma with neuroendocrine differentiation, neuroendocrine carcinoma.
Yeah, I think, my experience is whenever I can get fooled morphologically between squamous and neuroendocrine if I don't check the history. But most of the times when you have squamous cell carcinoma, it stains with P40 or P63. And if the neuroendocrine expression is there, it is very rare focal. So I would make a diagnosis of metastatic squamous cell carcinoma. I have not seen a metastatic squamous cell carcinoma showing diffuse neuroendocrine expression.
Yeah, yes.
Having that said, let me tell you, the big category of menins I was talking about, I have seen neuroendocrine carcinomas and mixed squamous cell carcinomas in right colon. So you can have a mixed tumor with neuroendocrine carcinoma and squamous cell carcinoma. That's different. But a true metastatic squamous cell carcinoma, for example, coming from head and neck or from anal canal, I have not seen neuroendocrine expression positivity that diffuse. We also did a small project. We didn't find any case like that. And remember P16, which is positive in neuroendocrine carcinomas. So if we are suspecting squamous cell carcinoma, especially from the GYN tract, please do HPV high risk in situ hybridization. P16 is not reliable. Yes.
Yeah.
And
Then
you
I
can
think
share
this
your
is,
experiences too. Please share your experiences. Maybe you have seen.
yeah,
at
yeah.
subset.
No, I'm
I'm
also yet
interrupting
to
in
see
between.
any.
I'm
Yeah,
interrupting in between, but what is the importance of SSTR2 stain? Do you get, what is your experience? Do you get request for the SSTR2 stain for therapy? For
So
somatostatic
actually, no, I don't get any request. The reason I talked about SSTR2 IHC is partly of my academic interest. We have a basic scientists who are here who are trying to, basically they are trying to give in a basic research some agents to increase somatostatin receptor expression in tumors, in grade 3 neuroendocrine tumors, so that they can give somatostatin analogs. So, and sometimes we have that in the stain. I think maybe neuropathology people use it. Some other subspecialty uses it. And to me, it's very satisfying if I'm thinking of neuroendocrine carcinoma and SSTR2 is not staining. Or if I'm thinking of grade 3 NET and SSTR2 is strongly and diffusely staining. I do understand the overlap though. So no, we don't need to do it in practice. We have the stain. I do it for interest. I think more useful stains seriously are P53 and RB. Clinical history, I think in a setting, morphological and clinical sometimes give you so much an answer, so much history, digging in the history, looking at carefully. I think that is seriously more helpful. Even P53 is not helpful these days. Now we are reporting grade 3 NETs with P53 mutation.
Yeah, I think actually we did also a research project with SSTR immunostain. But what I feel nowadays, our nuclear medicine colleagues, they do now the scan with these SSTRs. So it's, as you rightly said, SSTR immunostain is only for research. People do as a research, but we don't get clinical call to do SSTRs as IHC.
yeah.
One thing, lung neuroendocrine tumors, if you see in a metastatic setting, they tend to be very poorly staining for SSTR2. So even sometimes DOTA-TATE scan doesn't pick up those neuroendocrine tumors. So yeah.
Hello, Dr. Dipti.
Hello, Dr. Patra.
I have one question. Determining the primary site in a metastatic neuroendocrine tumor, does it helpful for management point of view?
it's helpful in management and what you said?
No, actually, suppose metastatic tumor of rectum, rectal primary neuroendocrine metastasizing to liver. So do you need to determine the primary site by running ISC for different sites? That means, is it helpful for managing the patient?
Yes.
Treatment point of view.
Right. So, you can debate either way. So to me, if you want to tell it's a small bowel neuroendocrine tumor primary site, which is often missed, it's usually talked about to remove those small bowel tumors because it produces fibrosis. Patient can undergo obstruction because of all that mesenteric changes it happens. So yes, in a way, if you know the primary site, you can remove the primary site. Because these days, even if you treat them, sometimes I don't know whether you get it or not. We get a lot of resections for neuroendocrine tumors, like they're resecting everything out. If you know the primary site, you can resect that out. But in a diffuse metastatic setting, let's say a patient has bone metastasis, too many metastases to be surgically removed, then I guess it doesn't matter where it's coming from. It's the same biologic therapy, same PPRT, lanreotide. So you can argue both ways. It's helpful to know the prime. And then, there is some clinical trials, not very good clinically. I hope there's some oncologists. Only pancreatic neuroendocrine tumors are treated, for example, suminetap, that anti-angiogenesis, not the small bowel. So there's some clinical trials for some site-specific tumors, but there's some clinical trials for all metastatic neuroendocrine tumors, regardless of the primary site. And we all know 15%, we will never know the primary site, 15%. So yeah, stains are sometimes, I have to say, this was research interest. We did this like 10 years back when Sambit was our fellow, but in practical life, sometimes we don't even do those stains. We say metastatic neuroendocrine tumor.
Yeah,
they're so good.
Okay.
The DOTA-TATE scan is so good, it will actually tell where the primary site is. So unless you want to do some stains for fun and to help them, it's fine, but not absolutely necessary, I think.
What is your experience in Merkel cell carcinoma in GIT?
In which one, sorry?
Merkel cell carcinoma in GIT. Have you encountered? How many cases?
Amphicrine, you mean?
No, Merkel cell in the gastrointestinal
Merkel
tract.
cell carcinoma. That was the only case I had, Merkel cell carcinoma, when we did polyoma virus stain. It was in the pancreas. The patient did not have a primary, non-primary site. So, and I think if we read literature, there are some extra skin Merkel cell carcinoma reported. Are they really primary de novo or they are truly metastatic Merkel cell? Don't know the answer. But because polyoma virus stain is so specific, regarding the thing about MSI, I know Merkel cell carcinomas are treated with immunotherapy, right? So that is the more important thing to diagnose Merkel cell, because that's a first line chemotherapy for Merkel cell, if I am saying correctly. Yeah, I have not seen Merkel cell carcinoma. That was the only peripancreatic biopsy. It was an eye opener because being a GI pathologist, I just said neuroendocrine carcinoma. I don't think about things. So now, I always say, at least let's do CK20, because CK20 is a very sensitive marker for Merkel cell. Yes. But of course, it's sensitive, not specific, because CK20 can be positive in other salivary gland tumors, other tumors. But when I went back to those cases we looked, all the CK20 positivity non-Merkel cell was not nice dot like the perinuclear. The Merkel cell is very diagnostic perinuclear. Yeah.
Thank you. Thank you. Well.
Okay, a question from one of my colleagues is that he's asking us, can we do INSM1 in lung neuroendocrine tumors?
Yeah, I think people do INSM1. In fact, I had some, Dr. Mukh, he's a very Twitter avid guy.
Sanjay Mukhopadhyay.
Yes, Sanjay. I don't know him personally because he does lung and I'm a GI pathologist. Yes. He has a paper about INSM1 and I actually wrote few things in my text box when I was talking about INSM1. I think, people use it INSM1 and they say if you have the only one marker if you want to do INSM1. but I'm a traditional pathologist. I really like synaptophysin and chromogranin. I see Merkel cell, a lot of, I'm trying to find that slide. Yes, it can be used. Anybody knows can pitch in right now. He did talk about sensitivity and specificity.
Dr. Dipti, I read that paper from
Yeah.
Dr. Mukhopadhyay, and he showed positivity even in squamous cell carcinoma and adenocarcinomas.
Yes.
And if we talk about some of our cases also, we seem quite a bit non-specificity, maybe in up to 5 to 10%. So I also still feel CG and synapto should be the tried first, and CD56 in a poorly differentiated setting.
So I'm totally agreeing with you. You know, it's a new for us, so I keep on trying that marker to see how good is it. I only knew, I do have it, his paper in Modern Path 2018. He says sensitivity of INSM1 similar to synaptophysin and CD56, and specificity similar to chromogranin. So basically he's saying in lung, if you do synaptochromo, you don't need anything else. But when the INSM1 started, the papers came, the tumors which you think are neuroendocrine carcinomas, if they're not staining with synapto and chromo, maybe INSM1 will be helpful. But now we are saying INSM1 is not specific. So I don't know again about INSM1 anymore.
Dipti, what clone do you use for INSM1? Because there's a question. That is the thing.
Don't know on top of my head. I have to check.
Because there was a question on that. Because INSM1, in my experience, initially when the papers came, we are very happy with the staining, but gradually more and more we use it in the non-neuroendocrine setting. We are getting positivity across the board.
I think so. I think so. Everybody shows me, you know, they are doing INSM1. There is some staining. I said, no, this is not neuroendocrine carcinoma. I think to be okay. Your experience, have you really done it in squamous cell carcinoma? I've seen strong diffuse positivity. So far, I've not done strong diffuse. I've seen patchy, weak, focal, but not strong and diffuse in non-neuroendocrine. Have you seen that?
No, I've never seen strong diffuse. You see some wishy-washy 20% moderate, weak kind of staining. Yeah.
So to me, the pattern of staining is very important. If something is pretty strong and diffuse, we have got to think of neuroendocrine carcinoma. But still, you know, I don't know.
Yeah, this is the usual story with all the IHC markers. When it starts, it's like very specific. But as we go on doing testing it in many tissues, then we start finding that it is becoming more and more non-specific.
Yeah.
Yeah.
So the other question,
you want to take the rest of the questions? I think Dr. Anuradha has some questions.
Yes,
he can take the rest of the questions.
Yeah, sure. Yeah.
You have to unmute yourself. Yeah.
Okay. Hi, Dipti. First of all, that was an excellent presentation. It covered everything.
Thank you,
Dr. One question, I think two of the attendees have asked. Case of metastatic neuroendocrine tumors should be grade. So I think, yes, you should grade because metastasis will show a higher grade of NET. And there's another added on to that, because grading varies with primary site. What's your...
So grading varies with primary site. I don't think only with lung versus GI, right? Grading is standard throughout. So because all the WHO grading is JEPNETs, is gastric. I'm a GI pathologist, so that I can tell you in GI grading is all the same, which is 3% cutoff and 20% cutoff for KI. Yes, for lung, we don't, you know, it's still a lot of argument about grading, you know, people still use mitoses. But Ki-67, I think people still do it, even if it's lung, clinicians want it. In fact, some of my clinicians also want for neuroendocrine carcinoma diagnosis. So I just give it to them. I've started doing Ki-67 for carcinomas as well.
Yeah, I think we also follow the same thing. And there's another question here. What are the basic markers to differentiate between primary liver NET versus secondary to liver?
That is very interesting question. I don't think there is any a specific marker. The only thing I know, and first of all, primary liver neuroendocrine tumors are so rare, and you have to really exclude the primary site, probably by doing an autopsy on a patient, whether this really represent primary or metastatic. But I've heard about biliary neuroendocrine tumors. I've heard about it. Never diagnose a primary liver neuroendocrine tumor. I never do, because I think most of them represent metastasis. And I don't know about, we are talking about neuroendocrine tumor here, but neuroendocrine carcinomas, yes, I have seen in association with hepatocellular carcinoma, in association with cholangiocarcinoma. And in situ albumin, I don't know if you do it, RNA in situ albumin, to me, it's a pretty good marker for primary liver neoplasms. I have not tried, I don't know how that will be useful to diagnose something, some tumor as primary in liver. I just had a case, looked like neuroendocrine carcinoma to me in liver. I did in situ albumin, it was positive. So, and patient has cirrhosis. So I do think in situ albumin can help in telling, in supporting the primary. But primary neuroendocrine tumor in liver, I have not had a case yet, so I can't talk much about it. If any one of you has it, would love to know about it.
Yeah, I think basically it's a diagnosis of exclusion, and also you need to correlate with DOTA traits and octreotide scan to know if there's any tiny focus which is lurking anywhere. So yeah, I agree. And also there's a question is, what is the morphological distinction between neuroendocrine cell hyperplasia and neuroendocrine tumors?
Okay, so we are talking about neuroendocrine cell hyperplasia in stomach, right? Yeah, right? Yeah, maybe
yes,
another
I think
topic
that's
could
what
be
they
on
are
organs.
mentioning.
Yeah.
Yeah.
So, okay. Everybody must be knowing about Dr. Montgomery, Elizabeth Montgomery. She is in, she was in Johns Hopkins and now she's in Florida. She's a great GI pathologist. She says anytime if an endoscopist can see the lesion, it is neuroendocrine tumor. That is a very simple way for telling her. If the endoscopist can see the nodule, it's a neuroendocrine tumor. Now, many times the endoscopist sees a nodule and they give it to me. I see neuroendocrine cell hyperplasia. I don't see neuroendocrine tumor. So to me, it has to be both clinical and pathological. A mass-like lesion, anything which is growing like a mass-like lesion. And it's very hard to define seriously. What is a mass-like lesion? Any lesion which has developed its own stroma, anything which is infiltrative, has invaded, for example, muscular mucosa, anything which looks like to you is a mass-like lesion, is a neuroendocrine tumor. If there is a distinction, it becomes very difficult to differentiate nodular neuroendocrine cell hyperplasia from neuroendocrine tumor, because you don't know it's a mass-like lesion, there are separate clusters. I'll tell you clinically, it does not matter, because only they will not do gastrectomy. And these are typically tumors we see as type 1 NETs arising in chronic atrophic gastritis, which is autoimmune. They will never do gastrectomies. They will only keep on doing repeat endoscopies and try replucking out all the nodules. So, if I see it's a mass-like lesion, I say neuroendocrine tumor. If there's a lot of nodular neuroendocrine cell hyperplasia, sometimes I do use the word dysplastic just to tell them it's almost neoplastic. And I explain to them in the comment that there is extensive neuroendocrine cell hyperplasia. But they will only do further management if they see a nodule. That's for me. If you have some different experiences, you can share with me.
But I think using the term dysplastic neuroendocrine hyperplasia is important based on the size, more than 500 micron, or peritumoral stroma, or irregular margin. That actually tell the clinician there is a need to closely follow up the patient, especially in autoimmune atrophic gastritis setting.
Yeah. I think it makes sense. Makes complete sense.
Yeah. And there's another question, type 4 gastric neuroendocrine tumors. When chroma is negative, is there any other promising marker since synapse is not specific?
Okay, so type 4 neuroendocrine tumor. First of all, what is a type 4 neuroendocrine tumor? In olden literature, type 4 were actually referred to as neuroendocrine carcinomas. So I believe this type 4, we are talking about PPI-associated neuroendocrine tumors, right? I think this is a very relatively newer category of tumors arising in association with PPI. Am I correct about it? or they are referring to neuroendocrine carcinoma. So the established ones are type 1 arising from autoimmune type gastritis, type 2 arising from menin and syndromes, and type 3, which is sporadic, which occurs in antrum. The type 4, I think recently they're putting type 4 is PPI-associated neuroendocrine tumors. And in general, for neuroendocrine neoplasms, yes, synaptophysin is not sensitive enough. If you're seeing only synaptophysin positivity, we need another marker. Dr. Das mentioned CD56 for polydifferentiated tumors. I would try INSM1 in that one. And I would go with morphology. And for neuroendocrine carcinomas, I'm very, like other neuroendocrine pathologists, if I want to call something as neuroendocrine carcinomas, even focal positivity for chromogranin for me is enough to say neuroendocrine differentiation. Tiny dot-like. So some people say, oh, chromogranin is negative. I say, no, let me look at the slide. And I will find areas where it's showing small areas of chromogranin A positivity. But I think INSM1 CD56 might help in that setting. What do you think, Dr. Nurada?
Yeah, I think so. Basically, the type 4 can be the higher grade neuroendocrine tumors. I think they're more like behave like carcinomas as well. So I've not used much of INSM1 in this setting, but yes, as you rightly said.
I think, please read the recent literature about it. I think I read recent literature sometime back. They really discourage using type 4 for those kind of tumors. It's neuroendocrine tumor or neuroendocrine carcinoma or a very rare subset where you cannot make that distinction, which I will say high-grade neuroendocrine neoplasm. I don't think type 4 is very well defined as such.
Exactly. Type 4 is something is still not very well defined. So it's better, as Deepti said, better to call it when you cannot differentiate as a neuroendocrine, high-grade neuroendocrine neoplasm and see comment in the comment.
That's my suggestion, because who knows type 4? Now you thinking type 4 is more malignant, I'm thinking type 4 is more PPI associated. So maybe there's some confusion in the literature itself.
Right. There is a question from Dr. Malika. She works with me. We recently have a biopsy, cervical biopsy with squamous cell carcinoma of the uterine cervix with around 15% cell, negative for squamous marker, keratin 5-6 and P40, but they're positive strongly for synaptochromo and 56. What should we diagnose?
Why do you think it's squamous cell carcinoma then? It's neuroendocrine carcinoma to me, what you're describing. They can look very similar. You can have neuroendocrine carcinomas in cervix associated with HSIL, associated with adenocarcinoma. So if anything looks neuroendocrine to me by those morphologic features, that criteria we discussed, and it's expressing markers for neuroendocrine, that's a neuroendocrine carcinoma for me.
Her question is about actually majority of the cell is squamous, but there is a 15-20% cell which looks like small cell and they have neuroendocrine marker positivity.
Maybe what she's talking about mixed menin. Maybe she's talking about menin which has tumor with mixed squamous and neuroendocrine differentiation. And I actually have a very nice case. I didn't show it in the picture. It is mixed. There are neuroendocrine areas, squamoid areas. You can tell squamoid areas have a little bit more cytoplasm, but the stains can differentiate very well. P40 areas, synaptochromo areas. Maybe they can see what is staining what. And maybe it's truly amphicrine carcinoma. I don't know. Weird things happen.
And Dr. Neha has a question. I think the question, how you suspect that in a case there is metastasis from breast, we should do GATA3 and androgen receptor. I mean in pancreas, synaptochromo with KI would be sufficient for NET.
The question is not clear to me. Can you say that again?
I think she's seeming to say like this is if there is a metastasis from the breast, should we do GATA3 only, or we should include GATA3 with AR, androgen receptor?
I'm not a breast pathologist. I've never done AR in that setting. If you do breast pathology, I do GATA3, and there's a new marker TRIPS. Where do you have that? It seems we have started using that. So GATA3, ER, TRIPS, that's what we do for breast. Sometimes if we are thinking it's breast, history is obviously very helpful. What I was talking about.
SOX10 also helps in breast. SOX10.
Yeah, I think SOX10, which are like a basaloid marker with a basaloid phenotype, right?
Mhm.
Yeah, so I think those markers can help. AR, I have not done in that setting, so I am not sure.
I
There
think
is
it
a
is
long.
important to remember some of the pancreatobiliary tumors also express moderate and patchy positivity for GATA3. So I
Yes.
don't have much experience about the pancreatic neuroendocrine tumor expressing the GATA3. So we should be cautious based on only GATA3 positivity.
I totally agree with you. In fact, we have some carcinomas, pancreatic primaries, and GATA3 is now more or less non-specific stain. But
Right.
that was a time we did, like it was many years ago. It really stood out. Remember that GATA3, for me, all the transcription markers, to be really relying on them, it has to be strong diffuse. I've seen GATA3 positivity in pancreatobiliary neoplasm, really not strong and diffuse. It could still happen. And I think I always put a disclaimer if I'm doing something based on the immunostains. I will say, although not absolutely specific, this positivity is seen more common in breast. So please look for breast primary. I never completely exclude that particular primary. I never completely rely on the immunostains. So that's true. Yeah, but for neuroendocrine tumors, we actually compared neuroendocrine tumors, breast tumors with neuroendocrine differentiation from neuroendocrine neoplasms. So this was very neuroendocrine neoplasms focused paper on GATA3. Adenocarcinomas, I'm pretty familiar, they can have GATA3. But even that said, I agree GATA3 can be positive in a lot of tumors and we should not rely only on one stain. If we are thinking of breast, one of my breast pathologists says, do GCDFP, do hemoglobin. So she makes us do other stains to rule out, breast versus other primaries.
Neeraj, what is your experience on GATA3 and all? You do a lot of pancreatobiliary pathology.
No, we don't use GATA3
Mhm.
for now, so I can't say much about that. There is one question somebody has asked, what is your experience on pediatric neuroendocrine tumors?
Pediatric neuroendocrine tumors.
Yeah.
So the two hospitals I worked with had a separate, we never had pediatric population. But sometimes people from pediatrics, they come in showcases if they have neuroendocrine neoplasms. So I think they are rare. It can, of course, happen. Maybe you have some experience. No, not really.
Yeah.
Not much. But younger patients, yeah, we can see neuroendocrine tumors, even metastatic. It's kind of sad, but I can't think of a recent pediatric case where I diagnosed a neuroendocrine tumor. Even sarcoma, yes, neuroblastoma. Neuroblastoma, we diagnosed one case, which was expressing neuroendocrine markers, and we thought of neuroblastoma. And that was not a young, it was like an early, young adult, basically. That also is in the differential.
Neuroblastoma is again beautifully GATA3 positive. This autonomic nervous system tumor, paragangliomas, neuroblastoma. So
yeah,
GATA3 is becoming more and more non-specific. The time we wrote the paper is almost 12 years ago. Yeah.
But but any one of you have experience of a neuroendocrine tumor primary known, like pancreatic, or showing strong diffuse GATA3? Right now, we don't know, right?
No, we haven't done that marker. When we know that it's a pancreatic primary, we have never tried doing GATA3 in that.
Yeah. So I think we don't know.
Sure.
Yeah, we don't know. But I know when we did it, when we did it, we didn't find a single case. But it was 2016, so it was long time back. Yeah.
Yeah, because as Prasanjit said very correctly, I mean, GATA3 positivity is usually weak to moderate and focal. I mean, probably we haven't seen diffuse, but none of us has done a systematic study on those kind of cases.
And also the recommendation is you need not try to do IHC to find out the primary. All you have to do is grade the diagnosis as NET and grade the tumor and differentiate whether it's a neuroendocrine tumor or neuroendocrine carcinoma. And then DOTA scan or Tract scan is the best.
Yeah. Yeah.
Is the best.
Currently, yeah, they do DOTA scan too. But
Yeah.
you know what? DOTA scan will not pick up tumors less than 1 centimeter, right? Small
Yeah.
lesion. And DOTA scan will not sometimes pick up lung neuroendocrine tumors because they don't express somatostatin receptors. So even though the recommendation says don't do it, sometimes if
You
they
can
don't
attempt
know
to do it. Yeah.
I just do it little bit.
Anita, can you unmute Dr. Bindu? She wants to ask some questions. Dr. Bindu.
Yeah. Can you hear me?
Yes,
Yes.
we can hear you.
Yeah, Dr. Swami, that was one amazing discussion which I've been listening and very useful. So I was the one who asked this question about this pediatric NET. So we had this 10-year-old girl, we had a specimen of appendix measuring 5 into 1.0, and now we have made an incidental diagnosis of morphological diagnosis of G1 by G2 NET. So I was just wondering what are your experiences, and as you said, maybe when we have submitted the appendix in entity, the base is clear, and so I mean anybody can help me out, like what more to look for. Like one clue I got is let us look for a neuroblastoma markers, and the child's ovary is normal. There's no stroma, ovary kind of lesion. So I could ask all the moderators and Dr. Deepti if you can give your feedback.
I'm trying to understand the question. There was a 5 cm neuroendocrine tumor in
appendix.
appendix.
No. I'm sorry, Dr. Deepti. This is a 10-year-old child. It's a 10-year-old child.
With how big of a tumor in appendix?
Morphology, it is grossly measuring 1.5 centimeter. It was an incidental lesion with a clinical diagnosis of acute appendicitis.
Okay.
So we have today submitted the appendix in entity. The entire appendix is now gone for fitting. And the base is clear of the lesion. Yes, Dr.
So I can tell you what I know about appendix. I think appendix is an outlier, even for, when we say neuroendocrine tumors are malignant tumors, appendix to me, in fact, this, maybe the paper is still there. I was not focused on site-specific lecture today. It was more like a NET versus NEC, but I heard in ECP, they did a very big study on appendix tumors, and it was a very nice study, lot of cases. And even tumors between 1 to 2 centimeters, they said, and I know it's a 10-year-old, but let's say anywhere, even in adulthood, if the margin is okay, actually just leave the page. Don't do anything else. They're incidental tumors. They practically never metastasize. And they actually compared with the cases who had right hemicolectomy versus who did not have right hemicolectomy, and who were just followed up, and the overall survival was good in all the patients regardless. So it was I'm forgetting the author's name. So to me, if it's a between 1 to 2 cm neuroendocrine tumor, your margins are fine. It looks like a very low grade incidental NET. I would not do anything about it if it looks like a diagnostic NET. You could do glucagons staining sometimes. It's helpful in this subtype of appendix neuroendocrine tumor, which behaves like a benign fashion. Glucagon positive L cell tumors, we say in appendix, which can also occur in rectum. But I will let all the senior professors talk. Maybe they have other experiences too.
But I think if you are diagnosing a neuroendocrine tumor in a pediatric patient, you can at least do an SDH-B stain, because if there is loss of staining, the clinician should investigate and look at the family tree and see if there is a history of hereditary neuroendocrine tumor or not. SDH-B can be helpful in such cases.
Yes.
And Dr. Sambat, is it possible to get that article with Dr. Deepti was talking?
Yeah.
Because this case, we have requested for an MDT discussions once the entire appendix is on our table.
Yeah, if you could email me, yeah, I can send it to you right away.
Perfect. Because honestly, I've reported in pediatric hospital, but this is the first appendix NET which I've seen.
Dr. Das, you raised a very good thing, SDH mutation or the immunostain. I thought we do it only for paraganglioma. Do you do for neuroendocrine tumors?
Yes,
Maybe in
which
a young
we
population?
yes. We get some requests from the clinicians because I forgot the name of the chemotherapy. If there is loss, the therapy sometimes there is an implication in therapy, and secondly, in pediatric patients, especially if there is loss, so there is a angle of hereditary tumors that should be ruled out.
Okay, so you would do only in a pediatric patient right now, right?
Yeah, and when we get a request from the oncologist.
Okay. All right.
Yeah, some oncologists, they do it. I mean, it's less than 30 years. I mean, patients with NETs, and at least as Prasanjit said, to look for paragangliomas and other kidney tumors with SDHB deficiency.
Okay. Yeah, interesting. Yeah.
That is very interesting. Thank you. And should we also look for a neuroblastoma also? Because this tumor is going up to the serosa, to the muscularis propria. The fat is free.
You know, neuroblastoma should look different histologically. Don't they look
Correct.
little aggressive neutral?
Yeah.
I'm thinking you must be very low grade NET with very low KI 67.
Just leave the child alone.
But 10-year-old, yeah, I don't have much experience. So I guess.
Same here.
Yeah.
Thank you so much.
Dr. Vijay has a question. Yeah, Dr. Vijay, please. Yeah. You can unmute yourself and ask.
Good evening. It was a very informative, nice, interactive session. We keep getting a lot of neuroendocrine tumors. So I would like to share one dilemma which we had. We had a 40-year female. He was diagnosed as small cell carcinoma. Actually, those blocks came for opinion for review. Very morphologically typical IHC done small cell carcinoma of cervix. She was treated with chemotherapy. I believe at that time also she had a very small nodule in the lung, which did not, of course, regress, and that grew in the size, which was subsequently removed. Very, very organite pattern. The organite pattern, there was absolutely no doubt, but Chi was very high, definitely more than 20. If I recall, it was around 40%. And I think after that, she was not given chemotherapy again. We called it as NET grade 3, based on the organite pattern. And she again had another nodule in the lung and also in the pleura, same pattern. So I have a question whether there's an entity in the WHO, they have not defined it, they have not given a name, but they have given such cases behave like large cell neuroendocrine carcinoma, like in between large cell neuroendocrine carcinomas and the atypical carcinoids. So do we think that this lung was a second primary? And I have done a couple of cases as ATRX and P53. I don't think it really gives a very clear picture in such cases of grade 3 NET versus, say, large cell neuroendocrine carcinoma. So what should we do? So question one, was that the lung nodule a second primary, not a metastasis, because it did not have a small cell morphology at all. And second thing is, how do we really resolve these problems of grade 3 NETs with high Chi 67 index, and especially on the small biopsy where we may not appreciate the organite pattern, they look more like sheets versus same thing, neuroendocrine carcinomas.
Wow, you had a very interesting case, and I'm sure all the moderators can also contribute. I know lung neuroendocrine neoplasms can present as metastasis in GI tract, and I think one of the site is small bowel, and I think that can be a very difficult question sometimes, especially if the immunostains are, especially in a high-grade setting, the immunostains are not helpful. In your case, when you said small cell carcinoma in a cervix, most small cell carcinoma in cervix are HPV driven. If it was HPV driven, it could be a separate primary. I have seen, and I've said there is a lot of challenging issues differentiating a grade 3 NET or atypical carcinoid with high proliferative index from large cell neuroendocrine carcinoma. I think there is a tremendous histological, immunohistochemical, and morphological overlap. And it is a problematic situation. But in your case, it could be two separate primaries. If one we can prove is HPV associated, that would be easy. If one is not HPV associated, and you're talking about small cell versus atypical carcinoid, I have never come across a case where I'm seeing atypical carcinoid and small cell. I have seen atypical carcinoid and large cell morphology, or grade 3 versus large cell morphology. I've never dealt with small cell morphology and grade 3 NET morphology.
No, this small cell was a different. She was treated with chemotherapy and subsequently underwent hysterectomy, and there was no residual tumor. So I also believe that these are two separate primary sites. My main problem was, again, to differentiate between grade 3 NET and neuroendocrine carcinoma.
Yeah, we could again, sometimes you won't get an answer in the biopsy. And I tell my clinician, I can't tell. Sometimes Ki-67 helps them in deciding for the management. If it is on the lower side, they treat like a G3. If it's a higher side, they will treat like a neuroendocrine carcinoma. I'll do all the stains in my power, P53RB. Sometimes they do molecular. Sometimes they might find MSI, So yeah. And I love to hear from other Dr. Das and Dr. Kumari and other doctors.
I think this is a difficult subject, but there is a cutoff of Ki-67 we use if other markers in combination are not working. If the Ki-67 is less than 50% or so, or their MSI microsatellite unstable, then we take them, possibly they are going to behave in a better manner, and possibly they are G3 NET. But there is no clear answer to this question. This is a difficult area.
I mean, this thing, whenever we have a G3 case, like we are struggling between a G3 NET versus a NEC, we tried this combination sometime, RBP53, ATRX, and MSI help, but sometimes we just end up telling them what are the facts, and they decide depending on that. That 55 magic number, it does help sometimes, but sometimes it doesn't help us to arrive at a...
We can try P16 as well now. It seems like promising science.
Yes.
That's really good.
In prostate, I do a lot of P16. If I have a RB P16 combo in a metastatic prostate where there is a neuroendocrine, and then that's a different ball game altogether. It doesn't like a GP.
So I do see, the Dr. Sarah Umetsu's paper from UCSF I was talking about, published this year. They had 45 pancreatic high-grade neuroendocrine neoplasms. So this is one way we can collaborate together. We can have all grade 3 NETs and NECs and an Excel spreadsheet. We can do a shared no patient information. We can put all the immunostains information. Maybe because these are all small scale studies. We can do one large study. And I think overall, we have to look at imaging, clinical, everything is, sometimes there's no good answer.
Dr. Deepti, I have one question regarding your last case. And I think there are one or two more questions from the audience. Like when I saw that picture, the first thing which came into my mind was pen. And people are asking you that how did you suspect to do EWS SR, that IHC? How did you suspect Ewing's in that? Because it looks like a papillary with small round cells attached to that core. And even I thought it could be a SPEN first.
This was a younger patient, 50-year-old. In fact, Stanford is submitting an abstract for USCAP, and I contributed that case. I think there are very rare pancreatic tumors which I have failed to characterize them in my practice so far. And I've been practicing for 20 years. I either do NET. This one was staining very focally with neuroendocrine markers, very focal, not convincing enough. And there was something about it. If you look at the morphology, it was not very typical of neuroendocrine. It had this, I was more thinking of solid and pseudo-papillary. And beta-catenin was negative. Everything was negative. Synaptochroma was hardly positive. In my case, it was not that positive, but I've heard people saying oh, Ewing sarcoma can have neuroendocrine expression. So ours was not that positive for neuroendocrine markers. So I can
And
show
was
you.
it-
SPEN is actually that solid cystic papillary neoplasm only, SPEN, which I'm saying. So I also thought
yeah.
first as solid cystic papillary neoplasm. So
In-
how did you suspect it could be a Ewing's?
But she
because
said
it didn't
beta
stain
category
like
was
solid.
negative.
It didn't
Okay.
stain like solid pseudopapillary,
Okay.
and we did everything. Beta-catenin was negative, and even I wrote in my comment, oh, solid pseudopapillary can be rarely beta-catenin negative because it's in the literature. And then we thought of, you know what? I don't know what struck me. Maybe I read something and said, okay, let's do CD99. And CD99 was positive. I said, oh my God, could this be peanut? And then we found the rearrangement. And now here I more and more. I have a friend from USC. She does soft tissue and GI, and she says she has maybe 10 cases like that. So probably there are some Ewing sarcoma. We are diagnosing them as neuroendocrine carcinoma.
Ewing's and Ewing's family and small cell, I mean, even neuroendocrine carcinomas, there is a similarity. We did a study like we see if it, I mean, sometimes keratin helps. Ewing's are usually keratin psi or keratin negative tumors, and NET and NEC is the keratin positive, and Ewing's is never very strongly positive for synapta and chroma. They show some sort of a staining. NKX 2.2 is a good stain for Ewing's. Again, small cell, I mean, some of my practice cases, I'm seeing small cells are also staining with NKX 2.2. Patchy staining for NKX 2.2. Again, what to do in those cases? How you, I mean, when you do, suppose a lab doesn't, and in India, a lot of labs, they do not have RB1 to differentiate Ewing's from small cell, or they don't have the facility for molecular. So how people should go about it? When you have a question between small cell versus
You know, I didn't share it, but I think that there was some peculiarities on that case. It didn't look like typical small cell too. It just looked like something.
it looks more like
bizarre.
SPEN. Yeah, it looks more like SPEN. And
Yeah.
now when you have a typical morphology, you have a small round cell tumor and the patient is really not very young and not old. So in between, and your because CD99 kind of non-specific, and a lot of places do not have RB1. P53 we cannot rely much. So, and KI is coming in between, not very high, not less than 20% or 20-25%.
But EWSR rearrangement you should be able to do, right?
Yeah, we have it in few centers, not in all places. Yeah.
Okay, so we can, you know, that it's not that uncommon. I mean,
Nah.
most tumors you're able to classify them.
Classify it, yeah.
The morphology is typical, the neuroendocrine markers, you get confirmation. So we are talking about really rare subset of cases.
Subset of tumor, yeah.
Yeah. So I really want to thank you for giving me this platform to, give this talk. We can, when I come to India, I can do slide sessions for the resident, bring real slides. Pictures are very different, pictures you can focus on what you're talking about. Real slides is completely different.
Prasenjit, Neeraj and Anuradha, Dr. Deepti is coming in April to Delhi and it's available for 2 to 3 weeks. So we can have something.
Yeah.
2 weeks,
we can call
2
you
weeks.
to
I'm cutting
Raebareli.
down your time, family time.
Yeah. We can call you to in UP, in Raebareli.
Anuradha already booked for Hyderabad and Prasenjit for Delhi, right?
No, she's here for 2 to 3 weeks, so she can move everywhere.
Thank you all for, for being here at this time, spending time and listening. And it was nice to see you all.
Great,
Should we end it?
Thank you so much.
Thank you so much. Yeah, thank you so much,
Very,
Deepti.
very
Thanks
nice
a lot.
talk. Yeah.
Thank you.
Thank you, Sambit, for actually coordinating this whole thing.
Yes.
Thank you, Sambit.
Thank you.
Thank you, Sambit. Bye. Okay.
Bye-bye.
Bye.